So basically, when your patient, and all of us who are spine surgeons, when a patient comes to you, their biggest fear is paralysis. Each patient says paralysis is their biggest fear post-surgery, and that's what the patient fears. It is also the fear which you install in the patient if you want to convince them for surgery, that if you don't get operated, you will get paralyzed. So that truly, the crux of spine surgery is paralysis, nothing else. Pain, screw here, CSF leak, those are the things which we know. But in the patient's mind, it's paralysis. That's the only word. Spine equals to paralysis, therefore never undergo spine surgery. But what about us as the surgeon? What is my worst nightmare, or as a surgeon, what keeps me awake at night before I do a case is the same thing, it's paralysis. So the patient's biggest fear and your biggest fear or the biggest nightmare are the same. So let's look at this. I think before I start this talk, I remember once when I was in Dr. Lahiri's unit, one of the other lecturers from the other unit did a surgery and the patient got paralyzed. And he came running to Dr. Lahiri, almost crying, sir, paralysis ho gaya, paralysis ho gaya. Dr. Lahiri told him, I shouldn't say his name actually, Nitin, I can just record it. Nitin, agar paralysis se dar lagta hai, to spine surgery chhod do. So this is one demon which you have to live with. So let's look at this 55-year-old male, CSM, came walking, cervical spondylotic myelopathy. We did some x-rays, it looked unstable, and there was cord compression. So most of us would do the same surgery, which is like a posterior decompression and fixation. Fairly good, everything looks good, but the patient woke up with a complete deficit. And that terrifies you. You're just waiting, and those moments, let me tell you, those moments are the most difficult for your coronaries. And you're waiting for the patient to wake up. In fact, I have a way of dealing with this. So what happens is these patients sometimes take time to come out of anesthesia. They are cold as well in the OT. And it takes some time to come out. So I used to get very stressed, waiting there, pair hilao, ungli hilao, pair hilao, ungli hilao. But I gave that. So I just go and I go away. I go have my coffee, go to another room and wait till the residents send me the message. And if they don't send me the message for half an hour, then I start getting dak. So anyway, this patient wakes up, no movement. Question is, what next? What do you do? No movement. This is the surgery which is done. What do you exactly do? Like panic, scream, cry, beg, because this is a complete deficit. And I always say that there is a huge difference between there's a Zameen Asman ka difference between a complete deficit and an incomplete deficit. Because a post-surgical incomplete, so I'm just giving you some tips in the middle, a post-surgical incomplete deficit cord will almost always recover. But a complete deficit is the one which you can be terrified about, because it may just not recover. It may be permanent cord damage. So question is, what do you do next for such a patient? Do you image him? Do you re-explore? Which of you would just immediately go and open the patient again? Anyone? Would just go and open the patient? Would anybody do imaging for this patient? Yeah, what imaging? CT? A CT and an MRI, both? Okay. Fine. So there are a few things which we do. I'll come to that in the later thing. But in short, we did an MRI, and this MRI clearly shows a huge compressive hematoma. And there was something to do there. So we went in, opened the sutures, drained everything, put in a drain, and then came out. This patient did actually recover. So neurological complications are the biggest bugbear. That's what we are the most terrified about in spine surgery, because you can handle pain, you can handle anything and everything, but an actual neurological disability you cannot handle. There can be general problems because of positioning, or sometimes because of the anesthesia, or it can be procedure specific, related either to the approach or the implants or the type of surgery. Positioning, I think Dr. Raghu in the morning did say, but there is something which is very odd, and this is before we knew this. When in KEM we used to operate patients lumbar canal stenosis and just do a lumbar, because getting an MRI in those days was difficult, let alone what else. So we used to just do a lumbar spine, and then 2 or 3 patients woke up quadriplegic, and the question is, how can a lumbar spine patient wake up quadriplegic? But as we now know, many patients have coexisting cervical stenosis, and just that twisted position or that bad position for that 3 to 4 hours of your surgery is enough to push them over. So point is clinically examine, point is get screening MRIs, point is your neck position has to be neutral. Don't leave it to the anesthetist. You have to do it yourself. Even just with intubation, these patients can go. So you need to be aware if this patient has a tandem stenosis or not. Peripheral nerve, of course, is not dense, but to a patient it may be, because like a patient who you want to operate for a lumbar spine lands up with a brachial plexus palsy, he's not going to be extremely happy. Procedure specific, implant related. So pedicle screw malposition is a very, very common cause. And the smaller breaches like in the lumbar spine, like inferior, medial, can cause a nerve root injury and very often presents as pain, but you can skewer the root and you can get a foot drop. Now a foot drop may not come under my topic as dense deficit, but believe me, an L5 palsy is a terrible disability for a patient to have, because the patient walks with a foot drop for the rest of his life. And if they also have gluteus medius problem, then they will walk with a lurch for the rest of their life. And it is a terribly dense deficit. It is a terribly disabling disease. Sublaminar wires as well are a problem. As Abhay pointed out, from that unit and from KEM, we use a lot of sublaminar wires. But believe me, there is a huge amount of expertise required. And the younger generation who's never seen one and tries to do one, you can really damage the cord very badly. There was a neuromonitoring study which was done which showed severe neuromonitoring issues on putting wires. So wires can be tough. Even hooks, if you don't know how to put them properly, something may slip and cause a problem. Procedure specific, there are type of surgeries, like there are some surgeries which are less, some which are more, but things like osteotomies. In an osteotomy, you're going all the way around the cord. You are also playing with the vascularity of the cord, and you are really separating two columns. You're using very hard instruments. You're hitting, you're chiseling, you're doing all that sort of stuff. And with the canal being tight, if there is anything, that cord can just give way. The same thing is high grade. I'm also going to take a few minutes extra.
Please
yeah.
So
let's look at this 45-year-old female, not too much, 2 minutes only. 45-year-old female presented with rapidly progressive paraparesis, and we got the MRI done, and obviously there was a cord compression over here. It's a tumor. Because of the rapid deficit, we took her up for surgery, and a dorsal decompression and fixation is what we did, because the dorsal spine was the one which was more involved. Post-op, patient again wakes up, absolutely no movements. So again, what do we do? What do we see? So this was a very osteoporotic lady, upper dorsal spine. We wanted to go quick in, quick out. We have this huge fear of bleeding. So the way I do it is I put in implants on one side first and then only open the tumor, because we didn't have any idea of what the diagnosis was. And this is the X-ray. So clearly these screws are not in the right place. And then the next is, of course, to do a CT. And the CT was obviously in the canal. It has sort of damaged the cord or pushed the cord to one side. And that would be the cause of the deficit. Now here is one situation where you need to take up this patient ASAP and remove or reposition those implants. So the causes can be again epidural hematoma, which I pointed out, and epidural hematoma can be because of many reasons. It can be also because your anesthetist is so good that during surgery your BP is very low, and then you don't do the hemostasis. Because the BP is so low, you don't do the hemostasis, and then in the end, when the BP comes up, there is a huge gush, and there is nowhere for the blood to go if you have sutured tightly. There can be some vascular injury which you have packed, and then that thing just opens later on, like there's an epidural which you have packed, but it just opens later on. And the biggest enemy is the blood thinner, and managing blood. If you see today in elderly patients, around 20% of them are on blood thinners. And managing those blood thinners, that balance between the cardiac and the blood thinner, like see that they don't get a blockage of the stent or a cardiac episode, at the same time they don't bleed, is a big trouble. And who will put out? The cardiologist will say don't stop. The surgeon doesn't want. So there are patients, and some celebrity patients, who landed up with a hematoma 2 days later, because you start the blood thinner, something bleeds, and you get a problem. Inadequate decompression, wrong levels, the edge of the laminectomy. It's a very interesting thing which I heard. In a dorsal decompression, once my patient deteriorated, and when you did an MRI, so let us say that the compression was at a D5-6. I did a D5-6 laminectomy. I'm afraid I don't have that case. But post-op, that D5-6 looked lovely. But at D4, that whole cord got kinked because there was a relative stenosis and there was a signal change there. So even these things can cause problems. Instability, battered root, etc. Let's look at this patient now. Another cervical spondylotic myelopathy, which is very common. Very, very tight. You can see how this cord is completely rat-tailed. But this patient came walking. Cervical laminectomy was the surgery, smooth and uneventful. I do these surgeries under the microscope. I use burrs, I use bone scalpels. I don't use nibblers or punches. There is no kerosene punch which is ever used. No entry into the canal. Vital stable, not that the patient went into hypotension, but the patient woke up paralyzed. Patient woke up paralyzed. What do you do? Of course, now between CT and MRI, if there is there are two reasons for doing a CT. First, one is that if there's an implant, then yes, you should do a CT. But the second reason sometimes is practicality, depending on where you're working. It's easier to get a CT first than to get an MRI. Because an MRI, it may take 2 to 3 hours. There may be some other patients lined up or a patient inside. Pushing the patient inside may be a problem. Anesthesia is a problem. Because CT can be done in 10 minutes because you go to the CT department, a patient from inside can be taken out and push the patient inside. But for this, again, there was no implant. And I luckily work in a hospital where everything is on site. We got the MRI done. And there's nothing, there is no problem. There is no problem, there is nothing to do. So in many cases, it is just cord handling or decompression effect. Now here there is no cord handling, I did the surgery. If the patient came from elsewhere, I might be tempted to say that there is cord handling. Sometimes we do things where there is cord handling. I've seen people operate I'm a little shocked even to see neurosurgeons operate very roughly on the dorsal cord, and I don't know how, because I don't even touch the cord. But the thing is, this decompression effect, this sudden decompression effect causes some bleeding inside the cord and can cause a deficit. Now when you have something like that, there is absolutely nothing seen on the scan, except after a few days you'll get a signal change, extensive signal changes going up and down. But more important, there is nothing that you can do. There's nothing you can do. You can't do anything. So what do you do when the patient wakes up without, firstly you wait. Don't be in a panic. Like I said, sometimes the anesthesia, the temperature comes up, the anesthesia goes down. Get the BP up. This patient cannot be hypotensive. Spinal cord perfusion, very important. MAP must be just raised to above 90, right? Replace blood, because even if the BP is good, but that BP is because of crystalloids or fluids and not the hemoglobin is low, still the oxygen carrying capacity is poor. So you need to actually give blood, because you ask the anesthetist and they say 2 liters blood loss, we've given 1 unit and we've given 2 liters of fluid. But that is very hemodilute blood. You need to give actual whole blood. Start them on high flow oxygen as well. Steroids is questionable, but this is one case where you don't question. You just give the bloody steroid, right? Give it in the spinal cord injury dose, the way it is described in NASIS, because by their definition, this is the earliest, this is within 6 hours, so it should work. Most important, always keep the set sterile. So I tell the people who come from the companies, they know that the set is not made unsterile until the patient wakes up and moves the toes. Never, because the last thing you want to do is you will need to revise this patient urgently, especially in a scoli. You want to open and remove everything, and they say autoclave. And in our hospital, autoclaving takes 3 to 4 hours because of some NABH and some requirements. That's how long it takes. It's not like maybe even in KM you can just put it in the flash or in smaller nursing homes. But in my hospital, it takes 3 to 4 hours for them to prepare a set because of their guidelines. So the set is always kept sterile. You carefully assess motor, sensory. The tone is very important. Just as a small thing to you, if a patient has a complete deficit and the tone is high, there is hope of recovery. But if the patient has complete deficit, no sensation, no motor and no tone, boy, you start praying. That's one which doesn't recover. Consider imaging. Like I said, CT, if there is an implant, or for speed, MRI, also important. You have to do these, there is no question. Don't panic, easy to say, but everyone is going to panic. Call a colleague, call somebody, call your friend. Don't re-explore without a reason. This is one thing which I need to really tell, because I've seen a lot of presentations and case presentations where people just take up patient got deficit, took to theatre, opened again. But open for what? You need to know why to open. By opening, you may actually push a recoverable position to an unrecoverable position. Like that cord is just in a little shock or dhakka mara, it's gone even worse. So that is very important. Don't just go and operate a patient just because it is there. Right? Speak to the relatives first. Tell them such and such a problem has occurred and we are going to do. Like I said, get a colleague. It will help you keep your nerves calm as well. And for all legal, medico-legal purposes, etc. And mentally try and go through the surgery as to what could have been the problem. Re-exploration is a considered decision. It is not like a knee-jerk reaction. The reasons must also be documented and discussed with the relatives, and you must take a fresh consent, please. For the re-surgery also, you must take a fresh consent and re-explore if there's something to do. And later on, there's not much neuro re-observation, constant dialogue with the relatives, and the rehab process and options. Preemptively, your consent must be solid. I don't know whether there's a talk on consent. There is no. Is there a lecture on consent? Yeah. So the consent, for me, all these neurologically difficult patients who may go like osteotomies, cervical myelopathy, those who've got issues, I take a handwritten consent in their hand, not in my hand, in their hand. So they cannot say we didn't know. You have written. मला माहिती आहे की माझ्या हातापायाची ताकद जाऊ शकते, परत येणार नाही. A video consent, an informed video consent that you may get paralyzed, you may never move, your bladder may go, you will never recover. You have to explain that it may be irreversible, and all descriptions must be there. So there has been one medical legal case where the judge said this is paraplegia and the word paraplegia wasn't there or whatever. So you say loss of movements, absence of movements, paraplegia, whatever, weakness, all the words have to be put in that consent so that the patient cannot say that this word was not told to me, right? There can be delayed paralysis as well, something like this, where a patient who's operated fell off the top of the implant and came back with a complete paralysis. And these are a little easier to handle, especially if they are slow. If they are catastrophic, then not. But if they are slow, then you can always do that. So, like I said, neuro complication is the most scary thing. It's what caused the most disability. Even maybe not a complete deficit. A complete deficit is a disaster. I mean, if you have a complete deficit, a paraplegic or a quadriplegic patient who's going to live for 30 years, that 30 years that sword is hanging on your head, every time that relative comes to you, you are like, you go into depression. But even smaller deficits are a problem. Like I told you, a foot drop is a problem. Another terrible thing is cauda equina. There are two reasons. One is that you have not documented pre-op, that this patient already had a borderline. But some patients for no reason get it. I have done a simple lateral disc and patient's gone, bladder goes. Nobody knows why. And that is, a bladder deficit is terrible for a patient. For you it is a bladder, but for them, they're on a catheter, they're on CSIC, they can't pee, they can't have sex. So it's a terrible deficit, and really keeps you awake at night. So anyway, a few Ramisms before Ram's lecture. A busy surgeon will have complications throughout his or her career. If anybody stands up and says 0 complications, he's lying. A surgeon who has no complications is a surgeon either who doesn't operate or is not truthful. How a surgeon deals with complications that arise intraoperatively or postoperatively is one of the key components that separates a great surgeon from one who's average. So when I say deal with, it is not just deal with the medical part, but even by the social and the legal part. There is no such thing as a simple spine operation. Like I told you, I have even had a cauda equina for a simple micro disc. And we've done the most complex osteotomies and nothing has happened. It's easier to stay out of trouble than get into trouble. I remember with Dr. Lahiri when doing anterior, people who asked to ask, sir, aorta injury kiya to kya karne ka? He said, aorta injury nahi karne ka. Simple, no? I mean, wow, how simple is that? You never get yourself into that situation. Now, why think कि वो aorta या vertebral artery काटने के बाद क्या करना है? मत काटो ना. Know your anatomy. The time expended in avoiding complications will be more than compensated by the time saved in not having to treat them. So if you're more meticulous, your approach is more, don't think you are wasting time. Because if you create a problem, you're screwed. The patient's well-being is paramount. As I said, second consultation, etc. And you should always operate with the meticulousness that you would wish as if they were your own patient. So, thank you.